Perfect. All right. Thank you, Dr. Bauer, for joining us tonight. I'm really excited for this one. My inner data nerd is ready to jump in. But Dr. Bauer, I'll have you kind of start. You're going to have your presentation, but maybe just give a quick introduction into who you are, why you're interested in this stuff, and why you're talking with us today. And I'll disappear, and then I'll come back in for the Q&A afterwards.
Oh, okay. No, thank you so much, Caitlin. So, hi everyone. I really feel privileged to speak today on Chiari malformation. I'm a pediatric neurosurgeon. I have a strong interest in a specialty in Chiari malformation, taking care of patients with Chiari malformation, and many of the complex things that may come with Chiari, including Syringomyelia and craniocervical instability, things like that. I currently work I practice in Texas, at Houston, Texas, at Texas Children's Hospital, and I'm a professor at Baylor College of Medicine. I've also written guidelines on Chiari malformation, and Caitlin and Bobby Jones, CSF, have been a part of that. And so I think deep thoughts about what kind of data we get from different studies that have been published, and how to interpret the data. What's the quality of the data? What does it mean to me? How should I change my practice based on the data? So today, what I'd like to do is talk a little bit about Chiari malformation, just to kind of go over the basics. I always like to do that, and then I'll do a deeper dive into data interpretation, and then we'll have some questions. And so I um, starting the here we go. So starting the presentation, here's the learning objectives, background, and causation of Chiari malformation. We'll go over the basic anatomy and physiology. We'll talk about the Chiari guidelines, Chiari databases, current studies. Where might I get data, and then how do I interpret medical studies on Chiari, and then where do we go from here? So Hans Chiari, he was a pathologist who worked in Vienna and Prague. Not a surgeon, didn't treat any patients with Chiari, but he described Chiari in 63 autopsy cases. And so that's how his name is associated with Chiari malformation. This is a MRI on the left of a child with no Chiari, and you can see the MRI on the right, no hydrocephalus. So on the MRI on the left, you can see the cerebellum, which is the back part of the brain. It's not below the bottom of the skull, called the foramen magnum. And on the right, these are the ventricles, these white areas, and you can see that they look normal sized. They're not enlarged. To me, that's very important of knowing what typical brain looks like when you are looking for what does Chiari look like, and why might it cause problems. And so this is an MRI of a 16-year-old boy with headaches. And this is an MRI that shows a typical Chiari malformation. So if you can see the red arrow, it shows the cerebellar tonsils, and that's just what we describe. That's what we call the sort of protuberance hanging down at the bottom of the cerebellum, which again is the back part of the brain. They're going below the foramen magnum, which is the bottom of the skull, and you can see they're pointed. They look like they could be obstructing, and that's how we think Chiari has symptoms. It obstructs the flow of spinal fluid. But in this patient, there's a normal connection between the skull and the spine, and so you can see that the brainstem is going straight down. It's not kinked at all. There's no kinking or sort of wedging between the skull and the spine. So this is Chiari 2. Hans Chiari described a few different variants of Chiari. Chiari 1 is really the kind that the main type of Chiari that most people have. Chiari 2 is slightly different. So you have something coming down through the bottom of the skull, but this is the cerebellar vermis and not the tonsils. and the whole brainstem is being pulled down. And so this is an entity that only is seen in patients with myelomeningocele or spina bifida. So what about a Syringomyelia or a syrinx? Or it's really just a name for fluid inside the spinal cord. You can see the arrow here showing the spinal cord, and the white substance inside the spinal cord is fluid, spinal fluid, and that shouldn't be there. That shouldn't be there. And so when we see that, that means some process is going on that is most likely blocking the flow of spinal fluid and potentially causing symptoms for a patient. So what causes Chiari malformation? So there are different thoughts, and I'd like you to think that maybe there may be multiple variants of Chiari 1 malformation, and this is why it's a little bit difficult to interpret data in studies because maybe all of the variants might be better treated in different ways. So anyway, so Chiari-1 malformation, the thought is that you could have a small posterior fossa. So the posterior fossa is this back part of the brain. So if it's smaller than usual, and if your cerebellum is programmed to grow to a certain size, then maybe your cerebellum will grow down through the bottom of the skull, or we call herniate down, and that's how Chiari is formed. Um, Another theory is that the cerebellum overgrows. It grows more than it should. You can also have acquired Chiari malformation where you have hydrocephalus or maybe a tumor, a brain tumor that pushes the bottom of the brain down. Or you could have something pulling down. So you can have something called a spinal fluid leak through maybe a tear in the covering around the nerve roots, maybe in your lower spine, that is causing fluid to leak out, and then it pulls the cerebellum down. Chiari 2 is different. It's a congenital problem. So this is something that happens during in utero, during gestation, before a child's born. And in this condition, spinal fluid is leaking out through the bottom of the spinal cord, where there's an open neural tube, and then this pulls down the brainstem and the vermis. So what imaging is needed if I have Chiari? Well, typically we'll order an MRI of the brain and an MRI of the spine. This looks for any problem in the brain, like hydrocephalus or a tumor. It evaluates the Chiari. It also evaluates the spine for spinal problems, such as fluid in the spinal cord, syringomyelia, or something called a tethered cord. We'll often get a CT scan if we believe there are bone abnormalities, and this might happen in maybe 5 to 15% of patients with Chiari malformation. And sometimes we'll get something called dynamic imaging, and this is called flexion extension imaging. It could be in the form of X-rays or a CAT scan or an MRI, and it looks for abnormal movement between the skull and the spine when you move your head forward and backwards. So what symptoms might improve with surgery? And what causes the symptoms? So there are some classic symptoms that when we look at studies that are published in Chiari malformation, so these are typically surgeons that have treated patients with Chiari and the patients have gotten better. And the surgeons say, hey, these symptoms have gotten better. So for Chiari 1 malformation, one of the most common symptoms to improve is a headache. And these are often headaches that are in the back of the head that become worse with something called valsalva or activity. And that's just when someone bears down, coughs, sneezes, maybe lifts something heavy. You can also have brainstem symptoms, and this is often from kinking of the brainstem. And this can be, these are more rare and they can be varied. So not everyone has the same symptoms, but you could have swallowing problems. You could have sleep apnea where you don't breathe at night when your oxygen level goes down, called central sleep apnea. You can have abnormal eye movements. Um, so there are some various symptoms. Maybe your tongue deviates to the side. And then another symptom of Chiari 1 malformation is the syrinx. Whereas for Chiari 2, symptoms are usually a little different. They're often more brainstem type symptoms, sometimes neck pain or headache, and sometimes the syrinx. who might benefit from surgery for Chiari? Well, patients with symptoms will benefit from surgery, and patients without symptoms do not need surgery. But determining what symptoms are related to Chiari can be challenging because there are overlapping symptoms. I've had patients with Chiari malformation and migraine headaches, and I counsel my patients before surgery that, the headaches in the back of the head with activity, those will get better, but the surgery will not help the migraine headaches, and we'll probably need to treat those with medication. Um, and so symptoms that are unrelated to Chiari will not get better with surgery. Importantly, there's no need for prophylactic surgery for Chiari malformation, meaning that there's no need to do surgery to prevent symptoms from occurring in the future. And so I'll go into a couple short studies. One is the natural history of a standard Chiari malformation. So these are patients with no symptoms who had sort of normal anatomy, just Chiari, often diagnosed maybe on a scan after a concussion. And very few of these patients who come to their doctor initially with no symptoms and just an incidental finding of Chiari, very few of these patients developed symptoms in the future and needed future surgery. Is it safe to play sports with Chiari malformation? So there are a couple studies, and there really has been found no increase in injury or concussion in patients with Chiari malformation who do not have symptoms. And so we generally think it is safe to play sports. Interestingly enough, at a meeting, we had a poll of certified pediatric neurosurgeons asking them if they would allow their patients with Chiari malformation to play sports after surgery if they were symptom free. And about half said yes and half said no. That being said, I don't know of a patient who has played sports after being treated successfully for Chiari malformation who has had an injury or a problem. So in general, we think it's safe based on all of the evidence that we have. The other thing that I think is important to think about as a patient is what kind of complications are typical with a surgery. So, what kind of symptoms typically get better, and what type of complications might you have? And so, one of the earlier studies, 500 cases, which is quite a bit, by one surgeon, Dr. Oakes, in 2011, found the rate of complications to be around 2.5%. In a more recent study, and this was not just one surgeon, but multiple centers, and a lot of the data was prospectively gathered. The complication rate was a little bit higher, and this is for PFD, which is the posterior fossa decompression, and posterior fossa decompression with duroplasty, PFDD. And the need for revision surgery, meaning the need to have additional surgery, was not zero as well. And so for the just the decompression alone was around 18%, and the decompression with duroplasty was 8%. So this means that there are complications that may happen. Now, that being said, these typically are things that will can easily be fixed. And so maybe the wound doesn't heal quite so well. Maybe there's a little bit of fluid under the incision that needs to be treated. Sometimes there might be a superficial wound infection that might need some antibiotics, but generally these are complications that can be easily treated. Um, so, what does Chiari surgery mean? And so, Chiari surgery means different things to different surgeons. And this is important to know. Different surgeons do Chiari surgery in different ways. And there are similarities among all of the things that we do, but there are differences, and I've actually studied those differences. But in general, for Chiari surgery, you're under anesthesia, so called general anesthesia. You have to open the skin and sort of move the muscles back. And then you remove some of the bone in the back of the skull to give additional room. Often remove the C1 lamina, which is the roof of the first cervical vertebrae. And then often opening the dura, the covering around the brain, looking at the outflow of spinal fluid to make sure there's no blockage, potentially resecting or cutting off part of the cerebellar tonsil, or tonsillopexy, which means cauterizing the tonsil, and then closing the muscle and closing the skin. Not every surgeon opens the dura for every patient. Not every surgeon resects or touches the cerebellar tonsils, and so this adds to some of the variability. But this is typically a picture showing the dura, which is the covering around the brain and sort of where the bone was removed from the skull and the first cervical vertebrae. And opening the dura and seeing the cerebellar tonsil come down, which is the Chiari malformation. So here's a patient example on an MRI. This may make it a little bit more clear. This is a patient who had Chiari and a syrinx headaches, also scoliosis, and had the posterior fossa decompression and duroplasty. So that's the bone removal with the addition of a patch. And you can see over here on the left that the patient has Chiari malformation, which is this pointed cerebellar tonsil, and it looks like things are crowded here in the bottom of the skull. You can see fluid in the spinal cord called a syrinx, and after surgery, on the picture on the right, you can see things are much less crowded. So there's room around the cerebellum, the back of the brain, and the fluid in the spinal cord has resolved, has gone away. So that's a successful treatment of Chiari malformation. So, what is complex Chiari, and is it important? So, this was a term that was recently originated um, uh, by Dr. Brockmeyer, and the term is Chiari plus additional anatomic problems. And so typically this means you have the Chiari, which is the cerebellar tonsils coming down below the bottom of the skull, but there could also be skull settling on the spine. So that means the skull is sinking down on top of the spine. Or you could have abnormal joints between the skull and the spine or fused bones. The skull could be poorly attached to the spine with some looseness. So meaning the skull kind of rocks back and forth when it shouldn't on the spine. Or the spine could be pushing into the spinal cord, causing brainstem compression and symptoms. So that's complex Chiari. And so is every Chiari malformation the same? And so I'd like to show you these pictures. Uh, this is a patient with Chiari malformation, a 16-year-old boy with activity-related headaches. If you look here, this is a 1-year-old boy. There's Chiari malformation, so the cerebellar tonsils are coming down, but you can also see this kinking between the skull and the spine. And this boy had motor delay. Very different than the first patient. And here's another patient, a 1-year-old girl with poor feeding. You can see hydrocephalus. These are large ventricles, fluid building up on the brain, but also Chiari malformation. And this is a 7-year-old boy who has Chiari malformation. You can see that on the picture on the right, but also has fusion of the second and third cervical vertebrae. And so this would be a complex Chiari malformation. And then this is a 16-year-old girl with headaches. And so again, very different. You can see the curving and kinking of the brainstem and the compression of the brainstem from the front. The also has Chiari malformation. You can see that here and back, but really it's because of the compression from the front and the settling of the skull and the spine. So there are other potential Chiari-related diagnoses. So there's an entity called hypermobile Ehlers-Danlos syndrome, which is a connective tissue disorder where patients have hypermobility of joints, and that just means the joints move more than in people without this syndrome. Klippel-Feil syndrome, which is congenital fusion of cervical vertebrae. So uh, kids are born with fused vertebrae, and you can imagine this could add stress to the vertebrae around the fused vertebrae. Basilar invagination, where the skull sinks down on the spine, or tethered spinal cord, which is where the spinal cord is lower in the spinal canal than it should be. And as you grow, you can have repetitive tugging on the spinal cord and injury. And then there are other some symptoms that could be related, like dysautonomia or POTS, which is postural orthostatic tachycardia syndrome, which means that you have different symptoms based on if you're sitting or you're standing. So these are potentially related, but the data is still out as far as how they're related and how they might affect Chiari. Do they cause Chiari? Do they make Chiari worse? Are they unrelated to Chiari? And so this goes into the second part of my talk, which really is how do I interpret the medical studies in Chiari? And so there's a methodology. If you're interested in this, I'd suggest that you look at it. This you could look it up online. It's called grade methodology. And this is a validated way that doctors can interpret the medical literature. So you can basically use the process. And so they tell you how to do it, how to rate articles, and then you can then understand the quality of the medical literature. And as a patient, what I might ask, and these are just practical questions to ask about a study. Um, Gosh, how many patients are in this study? Are there 500 patients? If so, maybe I believe the results. But what if there are just 5 or 6 patients, or a case report, one patient? Could this be a fluke? Is this finding real? Also, how many surgeons participated in the study? I find that if there's a single surgeon that publishes results, I think that's great. But I would love to see a study with 10 or 20 or 30 surgeons all getting similar results, because this means that we know why these results are happening, and it's how the surgeons are treating the patient. And so, if it's a single surgeon and no one can replicate the results, then maybe there's something that surgeon is doing that the surgeon hasn't taught, or the other surgeons don't know. Maybe it's there's something else going on, and so. So I find if there are multiple surgeons all getting similar results, then the study results are more believable. Is the data prospective or retrospective? So what this means is, did we collect the data as we treated a patient? So I see someone with Chiari malformation today. We ask about symptoms. I write them down that day so that I don't forget. Or is this retrospective, where we've taken care of patients and then we look back at the medical record to see what we did and how the patient was taken care of? The problem with retrospective data is that often we'll forget, or we don't write down all of the details of our examination or the symptoms that a patient might have had. And so then we may not have accurate sort of representative data to base our results on. Another thought is, has the study been repeated with similar results? And then just ultimately, do I believe the data? Does the study make sense? Do the findings make sense? And so you can look this up. Multiple national medical organizations all have their own guideline methodology. So this is the American Society of Clinical Oncology. This is North American Spine Society, American Academy of Orthopedic Surgeons, American Thoracic Society, American Academy of Pediatrics, and then the Congress of Neurological Surgeons. And so that's my parent organization. So all these organizations, they have guideline methodology. They're all slightly different, mostly similar, often based on the grade methodology. Um, so I I mentioned at the beginning of the talk that I wrote Chiari guidelines, and so I did that in conjunction with Bobby Jones CSF, and the Chiari guidelines had three main questions. So we talked about the diagnosis of Chiari malformation and the best available evidence, the treatment of Chiari malformation, and what symptoms are most likely to improve, is prophylactic surgery needed, etc. And then additional questions. So should we do posterior vasa decompression and duroplasty, cerebellar tonsil reduction? When will a syrinx improve? And so I highly recommend, if you're interested in the data, we did a very good job in looking at all of the data on Chiari, grading the literature, and then writing recommendations based on the quality of the literature, if we believed the literature was true or not, or how strong was the evidence. Um, when we did this, we evaluated the studies in this way. So there are level one, two, three, and four studies, and there are different types of studies. So therapeutic studies, this is treating a patient. Prognostic studies, so how well is a patient going to do? Diagnostic studies, how do we diagnose the problem? And so when we look at the data for level one studies, you can see there at the top. These are high quality, sort of randomized trials with statistical significance. And what that means is they're trials that were planned. The patients were randomized to a treatment or a control group, so either getting the treatment or not. And then there was close follow-up of all of the patients to make sure that every patient was accounted for when the results were written. Um, Level two studies are poorer quality randomized studies or a prospective comparative study. A level three study is a case control study. So you're looking at a case of something like Chiari malformation and then a control, a patient without it, and then you're trying to compare. And then a level four study is a case series. And unfortunately, the levels four studies, which are the poorest quality evidence, are what is most common in our literature. And that's because those are the easiest studies to do. A surgeon takes care of a certain number of patients and then writes about how well the patients did. And unfortunately, there can be a lot of bias in those studies. And so um, it's very important, if you do have level four data, to then do a very good quality level one or level two study to confirm the results. When we write guidelines, we try to link the evidence to grades of recommendations. And so we grade recommendations A, B, C, and I. And so A recommendation means that something's recommended. And so there's many studies showing, they're good quality studies showing that this is a good thing to do. You should do this. Um, Level B, grade of recommendation, is suggestion, meaning that there's some evidence that it's helpful, but we don't have enough evidence to call it a level A recommendation. Grade C recommendation is an option. And so that means that there's maybe some preliminary evidence supporting that recommendation, but it's not very strong. And I means insufficient or conflicting evidence. And so that means some of the studies showed one thing, some of them showed another, or the studies were very poorly done. And so we really can't make a recommendation. And so all of this, as a patient, I would say, um, why is there variation in the treatment of Chiari? And so I know it can be confusing to read different studies and different ways of treating Chiari, and wonder how come different surgeons are treating patients in different ways. Um, all surgeons potentially have access to the same published data. So this is true. All surgeons can go on the internet and look up studies, but surgeons do train at different programs, and there are different experiences during training at these programs. Surgeons also gain different experience treating patients with Chiari malformation. But I think part of the complexity is that all patients with Chiari malformation are not the same, meaning that they do not have the same appearance of Chiari on MRI, and when we saw those pictures earlier, and also don't all have the same symptoms. And so because of this variation in the anatomy and the symptoms, maybe there are multiple forms of Chiari that maybe should be treated differently. And this is a sort of a line of research that we have now, but we haven't quite figured that out at this time. Um, What's the current data for Chiari? Well, the Congress of Neurological Surgeons guidelines on Chiari malformation, you can look those up online. They're free, publicly available. Bobby Jones has a patient database and information. There's Park Reeves Research Consortium, which has also published high quality data. And then there are a couple outcome and success scales that are trying to better quantify these sort of variations in symptoms to see maybe there are, different types of Chiari-1 malformation, and so they should all be treated differently. So those are why those outcomes measures have been proposed. There are challenges in treating Chiari-1 malformation. Some symptoms that typically improve are straightforward. Other symptoms that may improve are more ambiguous. So the headache, again, is a reliable symptom to improve. Um, there are some patients that say they have brain fog, and this improves after Chiari decompression. It's hard to really quantify that. How do you describe that? Maybe every patient doesn't describe it in the same way. It's not common. Is there a test to test for brain fog? Not at this time, and so that's where it is more difficult to first understand that this is a symptom someone might have, and then understand that that symptom actually improved with surgery. There's also the variability in how Chiari is actually treated. So the size of the craniectomy, the bone that's removed, whether the cerebellar tonsils are removed or cauterized, the different ways to do a duroplasty, to sew in a patch, and the different materials you can use. Maybe it matters, maybe it doesn't. But until those details are um, uh, written down and in every research study so that we can see if those details make a difference. Until that time, it may be difficult to understand really what's the best way to treat Chiari. Um, there can be a placebo effect with surgery, and this is something I worry about, where patients might improve with surgery for a few months and then symptoms return, and maybe the symptoms weren't related to Chiari in the first place. And that's always a worry of mine when I do offer surgery to a patient. Children treated before puberty can grow. Their brain and skull are growing, and so these changes can cause reoccurrence of symptoms. And despite prior studies, there's really a lack of abundant, high quality, sort of granular clinical data on Chiari treatment and outcomes. And so this is really the challenge. And it's possible that there are multiple ways of treating Chiari and they all work. So a surgeon in India had proposed fusing the spine for Chiari. Surgeons in the US do that less often, but do that for certain reasons. Um, some surgeons remove just the bone and some remove the bone and do the duroplasty. And the Park Reeves study did show that for quite a few patients, both options worked. However, there were some patients that only had bone removal that actually needed the duroplasty. And so I find that counseling families and trying to educate families when I see them before offering surgery is often very helpful to understand, help the families understand the variation in how we can treat Chiari, what are the reasonable options and the pluses and minuses, and really make an informed decision for treatment. Well, today, I hope I did a good job in going over the background and causation of Chiari, the basic anatomy, the guidelines, and the database, and also really how to interpret medical studies on Chiari malformation. Where do we go from here? That's always additional research, but doing it in a very systematic and quality way. This is my team from Texas Children's. We have 8 pediatric neurosurgeons, and I want to do a shout out to Bobby Jones CSF. I appreciate their support. I think they do an amazing job for our patients and advocacy. And thank you again for asking me to speak today.
Thank you, Dr. Bao. That was great. I am going to go through what some people would probably find to be the more boring questions just because I like this stuff. I'll get them out of the way. First of all, these might be unfair to ask you, but can you like describe what the concept of regression to the mean is in the sense of like why is more when a bigger sample size is part of the study?
So why is
Why is a bigger sample size better?
Right, right. So, right, regret. So, what this means is that there's sort of a concept of a bell curve, and if you've seen that, there are some patients, some people in this world who are very tall, and that's how they're supposed to be, and some people in this world that are very short, and that's how they're supposed to be, and then this sort of bell curve sort of range of heights in between. And so if we have a study with just a few patients, then it's very possible all of the patients could be from one side or the other side of that bell curve. However, if we have more patients, then we're more likely to have a sort of an average sample of all the things that could be. And then we're more likely to have a real result. And so it's a statistical concept, but that's why a higher sample size is better for a study.
Awesome, thank you.
Yeah.
And then why consecutive patients? Why is that like a stronger evidence as opposed to picking as you go?
Sure. So that's a great question. So that means that we're capturing all of the potential variation. So think about this: if you have 100 patients in a study, and but if I'm able as a doctor to pick and choose who is in the study, then I might not choose some patients that would maybe change the outcome. So you potentially have a biased study, and so having the consecutive patients means that every single person is captured, and so you're capturing all of the variation, and you're not missing a sort of a data point that is sort of lost to follow up. That's something that we'll say for studies, and so that's why large sample size and consecutive patients is very important to having a study that's high quality that you can believe.
Awesome. And I'm going to do one more boring question, if you don't mind. And this probably is pretty easy, but what are some red or even like pink flags when it comes to believing a study's conclusions kind of like at face value?
Yeah, so yeah, I review for the literature. So I review articles that get published in the literature, and there's something called peer review where we look at an article, and we have to agree that it's worth publishing before it gets published in a journal. And so when I think of the data, sort of the punchline of an article, um, that's not the entire article. So as an author, I can have some poetic license as far as how I interpret the results. And so I may look at the results and say, oh, all of the patients did great. and there were no problems. And then if I look at the data, they might say, oh, there's a 20% rate of infection, a 10% rate of going back for another surgery. And so the surgeon may interpret the results in one way. However, I may interpret the results in a slightly different way after seeing the actual data. And so, so when I interpret a study, I look at that punchline, but I also look at the data to see if I think the authors are making the appropriate conclusion based on the data. And that does take a little extra time, and I do have a medical background, so it's a little bit easier for me. But that's why I suggest um, if you look at an article and it has just a few patients in it, it's it's hard for me to imagine that that is highly reliable sort of evidence. It may be a start, it may be a good idea, but when I look at a guideline, like the Chiari guidelines, someone else has looked at all of the data for me. Someone has made sure they haven't missed any of the data, and someone has reviewed the articles in detail, and so I put more weight into those findings than a single article. I hope that's helpful.
Yeah, yeah. And this is all right. I lied. There's one more boring question, but
Sure.
most of the patients that we work with are pretty, educated in the space, but anyone that's new maybe isn't going to be. But how are the quality of the journals themselves? Like, how do you know if a journal is good, or can you discuss the concept of like predatory journals a little bit?
Yeah, yeah. So that's a great question. So there are a couple types of journals. And so there are some journals, and these are journals that are often associated with a national doctor organization. So there's American Association of Neurological Surgeons, Congress of Neurological Surgeons. They both have journals. And in general, if I submit an article to the journal and it's accepted for publication, then it is free. The journal will publish the article without charging me. The bar to be accepted by the journal is pretty high, and so it means that multiple of my peer surgeons have read the article and believe it's worth publishing. So that's high quality data typically. And there is a concept called a predatory journal, and these are journals that are for profit. So they charge a surgeon to publish an article. Often the charges are quite high, and they may or may not have a peer review component. So there are some journals that if you pay them enough money, they'll publish anything that you give to them. And so you can imagine that in that setting, the journal is seems like they're out to make money, but not out to publish high quality data. So um, uh, that's a type of journal that I wouldn't put as much sort of stock in as far as re believing that the published answer, the published results are real results. So that's the difference. And journals are not necessarily rated, but there is something called a citation index where journals are their articles are cited or referenced by other journals, and generally the journals with a higher citation index are higher quality journals. But I would look for a journal that's associated with a well-known sort of national organization.
That's great. Thank you. I'll switch into some sciencey questions, diagnostics and stuff now. Um, there were questions that came in ahead that about how you distinguish between Chiari and secondary Chiari. So can you, I guess, quickly describe the difference between Chiari that's caused by something else and how you distinguish that in the first place?
Yeah, no, for sure. So, secondary Chiari can be from something in the brain, pushing the brain down, like a brain tumor, hydrocephalus, or can be something maybe pulling the cerebellum down, like a spinal fluid leak from the spine. And so it can be challenging sometimes to diagnose secondary Chiari from a spinal fluid leak, but it's pretty easy to diagnose secondary Chiari from a brain problem because you get a brain MRI and you'll see fluid building up on the brain or a tumor or something like that. Um, Secondary Chiari is not as common as primary Chiari, but that's the main difference.
And then as a follow-up, how common is something like secondary Chiari in a patient with, they use the example of like long COVID or chronic fatigue and like connective tissue disorders. Is it more common or same um, commonality?
I don't think anyone has really studied that. So I don't think there's an association with long COVID or things like that, but no one's really studied it. Chiari is somewhat common. 1 in 500 people might have Chiari, so for sure there could also be an overlap. Plenty of people have Chiari out there that don't know they have it. And that's because not every Chiari is the same as we saw in the talk. The Chiari looks very different from person to person.
That was good. Yeah, good point. Um, I kind of want to broach this question because I've heard it even in at work. People often say that decompression, quote unquote, is easy. It's a pretty common surgery. Almost any neurosurgeon can do it. So I guess the question is really, is there a difference between decompression surgery in general and a Chiari decompression specifically? And if there is, what would be that difference?
Oh, well, I mean, there's spine decompression, so you can have spine stenosis or narrowing, and that's a different operation, but um, that you would do, in the another part of the spine, like the cervical, thoracic, or lumbar spine. But I guess a decompression surgery can be routine, but again, there are nuances. And when I've talked with other Chiari experts, my friends in the community, and actually have done a poll of practice variation. There actually is some practice variation on how the bone is removed or how much bone is removed, how to open the dura, and so um, I would say there are nuances to it, and it's um, can be a sort of a routine surgery, but I think it's also possible to do a decompression and maybe not do a nuance, and someone might need another surgery because the actual reason, the pathology, the reason why the Chiari was symptomatic wasn't addressed. And again, the most common types of things are not doing a duroplasty and the patient needs a duroplasty, or doing a duroplasty but not opening a sort of a blockage in the flow of the spinal fluid. Usually it's a web of tissue at the bottom of the brain.
Awesome. And then we get this question a lot, and I never really quite know how to answer it, so I'll be okay if you don't know either.
Sure.
But how much experience leads to expertise, quote unquote? I know they have like that rule that I can't stand of 10,000 hours, but being expert in something. But how does a patient or even a parent who's just a little nervous for their kid, how do they know that they're seeing the expert on the matter?
It's a great question. So, I think you can be an expert from reading the literature. You can have read all the literature, or I can ask AI to chat GPT to summarize all the literature for me. You can be an expert by doing something. Doing an operation multiple times, and I'm sure different people become expert at sort of different points in their career. It may take one person, a few times to do the surgery, and they're an expert. Another, surgeon to do it more times than that. Ostensibly, every person uh, who has completed a residency and who has done become board certified is supposed to be an expert, in neurosurgery. But I find some people think deep thoughts about Chiari, and some people might think, well, it's an easy surgery, but maybe haven't thought about all the nuances. And so I think, to me, thinking about deep thoughts about Chiari, participating in research, um, uh, those are things to me that mean someone has knows everything about Chiari and is thinking about Chiari and trying to do their very best and taking care of every patient with Chiari. And so, but it's a good question. I mean, I think what does it even mean to be an expert? Really, it's when I have a surgery, I want to get better, and I think. Part of expertise is also understanding what symptoms may not get better. When maybe the Chiari isn't the cause of symptoms, and so that's again, the research, thinking deep thoughts, and thinking about not just the physical finding on the MRI, but the whole patient and all the symptoms. To me,
Mhm.
that makes a difference.
Absolutely. There was a question in the chat and one from beforehand, kind of about like failed surgery. So um, the question that came in ahead was just really about how to get on like a journey to make sure that they can get surgery into adulthood. And then the question in the chat is more about um, an unsuccessful cranial stenosis surgery at 15. Patient's now 33 and they're still having issues. So, I mean, how do you address, failed surgery X number of years out, I guess, is kind of.
This is hard. So, I think surgery can fail because for a couple reasons. So one could be you have it in childhood and then something changes, like the bone grows back, and then you need another surgery to fix the Chiari again. Another could be the problem was never fully treated. So you have a surgery with the bone removal, but you needed to have the duroplasty for extra room. And a third reason could be that the symptoms were never from Chiari in the first place. And that can happen where symptoms are from like migraine headaches. And so migraine headaches aren't going to get better with Chiari surgery. And so I would suggest if someone had surgery and symptoms persist to see a surgeon who thinks deep thoughts about Chiari, and then probably have imaging and just have a reevaluation, that to me, that would be the way to go.
And then just because this is kind of inherent in the question, Chiari 2, is that always in conjunction with spina bifida or?
Yeah, it's
Okay,
just with spina bifida.
okay. Um, there's a question in the chat that I want to get to. So 8 millimeter Chiari diagnosed recently from a neck MRI. Previously had a brain MRI that was clear. So does this mean that it had developed in that amount of time? Is it something that they missed? Is it like positioning? What's possible happening here?
It's hard to tell. It's maybe there's a little change with positioning, but probably not a lot. Sometimes it can be missed. The quality of MRIs varies, so you probably need to look at the prior imaging and compare yourself.
Absolutely.
Yeah.
A follow up on the guidelines question. Um, there are multiple groups that end up putting them out, and sometimes they're different. So the gold standard, can you just, and how can patients know which guidelines to believe necessarily and how to, determine that?
Yeah, so great question. So really it's how are they produced? And so the you can have guidelines that have surgeon personal opinion, and that can be the guidelines. So you basically ask a room full of surgeons, what would you do? Or you can have guidelines that are purely based on peer review literature, which is studies that are published that have gone through a rigorous review process. And so the guidelines that I helped write are the peer reviewed type guidelines, meaning that we only made recommendations based on published articles in the literature. But some guidelines may have expert opinion, and so that's how they can be different. So it doesn't mean that it's bad. Sometimes we don't have good data, and having expert opinion is helpful, but it also means that it's just someone's opinion and it hasn't been studied or backed up with good quality data.
Yeah, absolutely. And especially in this area, as you were saying, it's mostly level 4 evidence in the literature.
Yeah.
Um, this is like a post-surgery question. Um, how do I know which specialist my child should be seeing going forward? How do I tease out what's a surgical problem versus something like pain management or neurology? How do you typically counsel your patients going forward after surgery?
Yeah, so I see them and if all symptoms are resolved, then that's great. If they're not, then I try to figure out if they're um Chiari related or something else related, and then I'll refer my patients to the appropriate person. So I do that myself. I'm pretty hands-on, but that's what I would do. I would talk with the Chiari surgeon and then get advice.
Okay. Yeah, absolutely. I have two more questions. If anyone has any more, you can put them into the chat. But going back to diagnosis, I hate to do this to you. How do you diagnose what is a chronic headache? So how can someone like a parent, especially if it's like a younger kid, how can they tell the difference if they're just having like a tension headache? I get those all the time, or like a migraine or like a Chiari headache. Is there a way to tease that out, especially if it's not your brain that you're living in?
Yeah, it's super hard, especially in young kids or kids that can't express themselves. And so I often find doing a headache diary, just gaining more information, having the child see a headache neurologist for a second opinion, doing those things can be very helpful.
And then longer term. So do you have suggestions about tracking? I guess you kind of touched on it here, but tracking symptoms post decompression. So this parent's nervous that the symptoms are going to come back. How long after surgery even should you be watching? I know you mentioned the placebo post
Yeah.
surgery, which I'm fascinated by. I love the placebo effect, but
Yeah.
how long do they wait, and is it something that they need to worry about at all, really?
No, so often if you're skeletally mature, so you're through puberty and you're a couple years out from surgery, it's pretty rare to have symptoms return. And so I always counsel my families, and after I follow them through skeletal maturity, then I say, hey, if you develop any weird symptoms, anything new, let me know. But it's pretty uncommon to have someone 10 years later develop symptoms again.
Awesome. And one last question. So you're pediatric. As a patient's getting kind of close to that, not a kid anymore age, do you typically continue to see that patient? Or do you transition them to an adult provider to kind of follow them over time? And what is that process like at Houston, I guess, specifically?
Oh, oh, sure. No, I follow patients into young adulthood, and we'll keep treating them until they're better, and then generally I don't need to refer to an adult surgeon.
But And then I think we're running out of time. So I just want to A, thank you for this. And then B, if anyone wants to get in touch with you, how can someone do that?
Oh, sure. Yeah. So, yeah, so my pleasure, my absolute pleasure to help do this. I do have a website. It's through Baylor College of Medicine, and my email is on there. Or you can touch base with you, right, through Bobby Jones, and people can reach me that way. But yeah, my email is on the Baylor College of Medicine website, and so. Yeah, it's my pleasure. I love thinking deep thoughts about Chiari and helping people, and I think there's still a lot that we don't know, and so I think we need to continue our very thoughtful, high quality research efforts. But thank you so much for asking me to speak today. I really
Yeah.
appreciate it.
Thank you for speaking, and thank you everyone for joining, and the video will be available soon. Thank you.
Okay, bye everyone.